Good morning and welcome to this morning's huddle or webinar. My name is Daryl Moon and I'm excited to be with you today. This is the 11th webinar in our series of short 30-minute webinars on the best practices of managing population mental health, brought to you by Going On Offense and sponsored by Resilience Pro. The recordings of each of our previous webinars are available on the goingonoffense.com website. And we would encourage you to take advantage of those and check those out. Clearly, the pandemic has heightened the need to address mental health. The uncertainty that we're all facing is having a devastating effect on emotional well-being across the country. These webinars are being conducted to share best practices of supporting emotional well-being and managing population mental health. So far in this series, we've addressed the following topics: integrating mental and physical health, overcoming the stigma barrier, technology that monitors the emotional well-being of populations so a true preventive maintenance program can be implemented to maintain optimal mental health, how to attract and retain top talent through supporting emotional well-being, filling the holes left by many EAPs, proactive emotional health and measurement-based care, the role of technology and mental health apps, ensuring prompt access to the right mental health provider, mental health best practices for youth, and last week our focus was on managing serious, persistent mental illness. Today our topic is managing the patient's needs, not their benefit. Please feel free to send in your questions through your control box, and we'll address those after I go through this short presentation. By the way, the presentation is available to download if you'd like to through your control box, along with a brochure of Resilience Pro, which is the sponsor of this series. Okay, so let's discuss today managing to the patient's needs, not their benefit. The outline of our discussion today will be, first of all, industry's common practices. 2, putting the patients first or their needs first. And 3, we'll talk about some of the cost savings of an abundant strategy of managing population mental health, where you do put the patient's needs first and you abundantly provide services. So let's talk first of all about industry's common practices. And to start off with, let's talk about the fact that there's no blood test for mental health. Then we'll talk about the financial incentives and the impact that they have on opinions. And then we'll talk about the need to align incentives. So Dr. Thomas Szasz made the comment, there is no blood or other biological test to ascertain the presence of a mental illness as there is for most bodily diseases. Psychiatric diseases, however, are merely the opinions of the observer. So whether it's a psychologist or a psychiatrist or a therapist or a social worker, they're trained in observing the patient's behaviors and then through their observations declaring a diagnosis, determining that the patient has a psychiatric disease. Well, we can't ignore the fact that there are incentives, financial incentives in a fee-for-service model that impact those opinions. A primary con of a fee-for-service payment model in healthcare is that it offers little or no incentive to deliver efficient care or prevent unnecessary care. And I've seen this firsthand where often because it is an opinion and because financially the provider has more to gain by providing more treatment, often there is an incentive to make that opinion in the best interest of the provider. We can't ignore that this has an enormous impact on the treatment of mental health. What does their benefit offer is often what I've heard in this mental health space as the question to determine what treatment would be appropriate. The excuse is often used, they need far more than the benefit offers, so we'll simply offer up to what the benefit is. There's an ever-present conflict in the mental health industry between the providers and the payers to deal with this conflict. The providers have an incentive to updiagnose or to justify continued treatment, and of course the payers or the purchasers have an incentive to try to drive down or to restrict, and so that conflict often creates an adversarial relationship between the payers and the providers, and providers are constantly having to check T's, cross T's, dot I's in order to to justify. They're requiring constant justification from providers before they get payment, and that creates this adversarial relationship between the providers and the payers. In most industries, there is an alignment of incentives, and there's a need to align incentives. Generally, the goals of the customer and the producer are aligned. Get or make the best quality product for the lowest price. That's not the case in healthcare. It's the one industry where that general principle of aligned incentives does not exist, and I've seen that firsthand for over 35 years. The goal of providers is to provide treatment. The goal of the purchaser or the companies who offer benefits is to create healthy, productive employees. That misalignment exists, and if employees are healthy and productive, they need no treatment. Hence, providers make no income. My own experience many years ago running 10 different hospitals as either the CEO, CFO, or assistant administrator, 8 of which were psychiatric hospitals, I saw this misalignment firsthand. I ran hospitals in Utah, California, Texas, South Carolina, and Illinois, and it didn't make a difference where it was, but in the healthcare industry, there's this serious misalignment of incentives. I felt like as a hospital administrator, I certainly sat at the top of the food chain when it comes to healthcare, because if you look at where healthcare dollars are spent, the majority of them are spent, 40% are spent at hospitals. So a large portion, the largest piece of the pie, is certainly in the hospitals. And as a hospital administrator, I felt like I sat at the bottom of the cliff, deciding where to park the ambulance to catch the most number of patients to fill up my beds versus putting fences at the top of the cliff. There was nothing in my job or in the way I was managed or in the way I was incented to prevent people from coming in the hospital. The whole focus was on how do we get as many doctors to admit to our hospital versus somebody else's hospital. I had the opportunity many years ago, over 20 years ago, to leave that treatment side and join a team of behavioral health innovators back in 1996 who envisioned a whole new model of managing population mental health. It eliminated the middleman or insurance company and created a direct relationship between providers and employers. It was a capitated environment where the providers took the financial risk with the anticipation of no annual increases. So profits were derived from keeping people healthy and early intervention and focusing on the needs of each patient versus increasing the rates every year or being affected by this misalignment that the more services we provide, the more money we're going to make. The goal of these innovative leaders was to prove that the model would work, and it has. It's a win-win-win. The individual wins because they're healthier and happier and more productive. The providers win because the profits are coming from keeping people healthy in the first place. And employers win because it lowers their costs. Putting the patient's needs first. So let's talk a little bit about how important it is to managed to the need of the patient versus the benefit. The key to this type of shared risk aligned system is early intervention. Clearly now the focus is on how do we put a fence at the top of the cliff, as well as not providing limits in the preventive level of services, and then creating treatment intervals without walls. So let's go through each of those. Early intervention. One of the most important things that any organization can do to provide early intervention is create a culture for the organization that promotes addressing emotional well-being. And the next thing is enhancing awareness of how important it is. Some examples that we went over a few weeks ago in a previous webinar that an organization can do to improve their culture is have an open door policy. Basically be open to this need to address emotional well-being. Now, the pandemic in many ways has helped that because everyone's suffering. Everyone's experiencing stress, challenges, a great deal of uncertainty. And so there has been a little bit more of an open door to discuss mental health symptoms and stress and depression and grief and the challenges that come from a worldwide pandemic because we're all in the middle of it. One thing an employer can do is listen. It's important that an employer gather information about what people are needing and how sometimes empathy is what people need more than anything. They don't need to be told how to go fix it as much as they need to know that the leaders in the organization empathize and understand. Keeping a pulse, having a monitor, being able to keep track and get a feel for where the employees are is incredibly important at developing a healthy culture to support emotional well-being. Voice commitment. One of the most important things that employers can do is literally voice their commitment to address this issue and their commitment to their employees and their overall well-being. Employees want to share. Employees want to know that their employers care about how they're doing and even the struggles that they're experiencing. One of the most important things that an organization can do to build a culture that's supportive of emotional well-being is to equip supervisors and managers with the kind of training that allows them to be a catalyst at engaging employees in services early. There's no question that we all face difficult, critical conversations throughout our lives, and sometimes we're better equipped to deal with those than others. If a supervisor or a manager is well trained on having difficult conversations with employees who they know are struggling, clearly their work is being affected by those personal challenges, and you don't necessarily want the managers to be the ones fixing the problem. But managers can play an incredibly important role at engaging the employee in seeking help through, let's say, a preventive level of care like an employee assistance program. And knowing how to make that recommendation and how to get that person hooked up with an EAP can be an incredibly important strategy that an employer can implement at engaging people in early intervention. And then, of course, communicating resources, making sure that your employees know the resources that you make available, whether that's internal or external. Most companies offer a tremendous amount of resources, but sometimes the problem is people don't engage in those. And so making sure that those resources are communicated frequently. A good example is an employee assistance program. Often they're touched on briefly during open enrollment, or a benefits booklet might indicate that there's one available, but that's about it. And maybe a poster that goes up in a break room. But having regular, constant communication, making sure people know and are aware of preventive services is an incredibly important strategy. The other thing is enhance awareness. One of the things that I've seen employers do that works extremely well, and partnering with employers, we've seen the area of just creating ongoing workshops on various topics. The category of emotional well-being covers a huge variety of topics that often are of great interest to employees. And so having professionals come at the worksite, and now even in a remote or a workshop that's online environment, can still address those same issues. Some examples are, how do you cope with COVID-19? What are some ways we can be resilient during these difficult times? Parenting issues. And now more than ever, parenting issues are being mixed up with work-life issues, and so addressing those and actually providing education in those areas. Managing your money and relationships are incredibly important at addressing emotional well-being. They're usually the greatest reasons for why people experience stress. Aging parents. Many are finding themselves in a position to support and help their aging parents. And then, of course, addressing addictions, which come in many varieties, and helping people understand how they can receive help at addressing addictions that are affecting their productivity. So let's talk about those preventive services. One of the important things that a group can do or a plan can do at better managing to the patient's need versus the benefit is not have limits on the preventive services. Employee assistance programs, which are the popular preventive strategy to address emotional well-being, often and in most cases come with limits, number of visit limits. This is a great example of having to manage to the benefit versus the patient's needs. What this does is it often creates a barrier for the individual. If, let's say, the employee assistance program offers me 3 visits, well, do I really want to start with a therapist or a counselor addressing my concerns, knowing that I'm limited in terms of how many times I can go? By not setting a limit on these preventive levels of services, and basically saying to people, look, if it's the kind of service that will respond to a preventive level of care, you can get all the help you need without any session limits. Now, there are only one that I'm aware of, but there might be a few others where the state laws do not allow for an unlimited employee assistance program. For example, California has a law that requires employee assistance programs to put limits on the number of visits. Limits within EAPs, which is a general definition of a preventive level of care or an EAP, can be created through the type of care. For example, instead of saying I'm going to limit the number of visits, I can say I'm going to limit the EAP to providing care for those who need solution-focused counseling. Hence, if you need something more than that to address your needs, then you'll be referred on to the benefit. But we found that 80 to 90% of everyone who are in need can have their needs met through solution-focused counseling, which can be provided in this preventive level of care. Hence, no need to be diagnosed as mentally ill. There's no copays to worry about. Nobody has to, pay the high deductible. And in today's environment, a lot of high deductibles are keeping people from reaching out and using the services for mental health, because if it's a $4,000 or $3,000 deductible, all of their mental health care could very well fall within that, and they're paying that out of their pocket. And so they'll not reach out for help. So providing a preventive level of care where there is no copay, doesn't need to be diagnosed, but not putting a limit on the number of visits is a wonderful way to address the patient's need and not or manage to the need and not the benefit. Let's talk about treatment interventions without walls. Another place where I've seen this in an extensive way is that often insurance plans handcuff providers because of the restrictions or limitations that they create. Now, we know with the mental health parity law that some of the limits that were around for many, many years have been relieved, because you can't offer a mental health benefit that has limits that don't also exist on the medical side. So, for example, the number of visits to a therapist or the number of days in a hospital. If you don't limit that on the medical side, you can't limit it on the mental health side. That's helped to eliminate some of those limits, but there's still a lot of limits and restrictions. For example, often within insurance, there are things that are CPT codes that you can bill for. Well, if what the patient needs is, for example, some remote treatment options, and there are many that can be used, well, if there's not a CPT code for that remote option, you're limited. In our case, because we aren't an insurance company, and because we have the freedom to do what the patient needs, we're able to use a lot of resources and strategies that there aren't otherwise a CPT code for. For example, treatment in a patient's home. We talked about this a few weeks ago, and particularly with adolescents and youth, it's incredible how more effective you can be at treating an adolescent's needs by going into their home than to simply require them to come to the office, because the CPT codes basically say, okay, what was an office visit? Non-traditional providers is another example of where insurance companies will restrict who can provide services, but when you take some of those restrictions off, there are a lot of other resources and providers that can be a part of the team that help patients, whether they're coaches or holistic practitioners or alternative practitioners, that can be a great part of the team in supporting a patient that traditional insurance doesn't pay for because there may not be a CPT code. Unconditional or unconventional support systems. Often the support system that's around a patient is one of the most vital things at helping to manage difficult, particularly chronic mental health patients. And being able to access those resources and actually make those a part of the treatment plan, where otherwise they may not be allowed through a traditional insurance plan, is also important. Case rates, how you pay the provider and how you partner with the provider, even on case rate basis, are things that insurance companies, that doesn't work. The TPAs, the billing systems don't work. They don't know how to handle a case rate of any kind. So those are some examples of interventions to provide treatment that don't have the typical walls, where you take the walls off and you uncuff the providers and allow them to do things that otherwise they wouldn't have the option to do. It's been inspiring to be a part of case management meetings over the years where the long-term needs of the patient are the priority. It's no longer, well, they only have so many visits left, or we can only provide the certain services because of the CPT codes or whatever. It's what does the patient need long-term to help them experience a happier, more productive life, but also to mitigate the cost long-term, not just for this year, not just for this plan year, but long-term. So let's talk just a little bit about some of the cost savings of this abundant strategy in terms of offering mental health services by giving people the care they need when they need it in an abundance. We've proven that strategy is less expensive and far better at providing quality care than your typical fee-for-service restrictive managed mental health. The first case study that I'll show, or we'll talk about, is an employer that has 50,000 members, $5 million in mental health claims savings between 2016 and 2018, $31 million in claim savings if you then bring in total claim savings. The ROI in this particular case study was 7 to 1. They saved $7.75 for every dollar spent. Just to show you a graph, here's an example of just the behavioral healthcare claims. The actuarial benchmark was 2138. This 50,000 members over that 3-year period of time had 23% less total costs in mental health care claims than the group of the actuarial benchmark. And that represented a $4.86 of behavioral claim savings. Now, one of the things that's most important to understand is that the behavioral health care savings are really small compared to the potential medical savings. HERO, the Health Finance and Research Organization, did a study a number of years ago showing that the risk factors that have the biggest effect on all medical claims are depression and uncontrolled stress. When you use Milliman's study that shows the impact by integrating mental health and medical care, the estimated savings of this particular strategy was $30.36. So the cost of the combined program was $3.92 between 2016 and 2018 per employee per month. The total savings was $30, giving us an ROI of 7 to 1. Okay. This is another case study of about 3,000 employees where the behavioral health care claims remained flat for pretty much a decade, which is pretty unheard of in the medical world, to be able to keep healthcare costs the same for as long as 10 years. So some examples of how this abundance strategy has worked very effectively to both cost save as well as limit or to level the cost of healthcare. So in summary, as I finish this presentation, we've addressed what the industry's common practices are, how important it is to put the patient's needs first, and the cost savings of an abundance strategy. Would love to encourage those of you that are participating in the presentation to submit questions that I can answer for you. I'm going to take a minute and just let you send in your questions and we'll address those. Okay, has the mental health parity law changed things, and if so, in what way? There's no question that the mental health parity law that went into place about 10 years ago has had a pretty significant impact on particularly limits. Before it was very common to have a certain set of limits on the number of visits, the number of hospital days, and that requirement, or the requirement to eliminate those limits if they don't exist on the medical plan, has truly impacted the mental health industry in a good way. Okay, how were we able to get, or how was it that a hospital was willing to actually change their paradigm? Because traditionally insurance companies are incented, or hospitals I should say, are incented to have more hospital beds. Actually, this is a very innovative hospital in Utah that was led by a very innovative executive director that sees the big picture and was willing to venture into a new model where on the short term it might feel like, well, we're going to have fewer patients in the beds, but on the long term we're going to be able to make a profit by reducing the number of people that need care. And so it was really just an innovative group of people with an innovative strategy that was put in place. Any other questions? Not seeing any, let me just conclude today's presentation by mentioning that Resilience Pro is the sponsor of these series on managing population mental health. There is a brochure describing the services of Resilience Pro, which is really a composite of all these best practices being now delivered to employers across the country. Today's webinar concludes our series on best practices of managing population mental health. Next week, we'll be starting a new series on best practices of workplace mental health and well-being. Please join us next Wednesday as we review a white paper that the Health Enhancement Research Organization has put out on employee mental health and well-being, emerging best practices and case study examples. We hold these webinars every Wednesday at 9:00 a.m. Mountain Time. Would encourage you to join us again for upcoming webinars. And remember that the webinars are recorded, posted. You're welcome to go back and review any of the webinars we've had in the past. And thank you for all of you that have joined us and participated in these. And we look forward to seeing you again in upcoming webinars. Have a wonderful day.